Hello students, welcome to this session. Let's study immunodeficiency disorders. Immunodeficiency, a condition where the defense mechanisms of the body are impaired, leading to repeated microbial infections of varying severity and sometimes enhanced susceptibility to malignancies. So there are two types, primary and secondary. So primary results from abnormalities in the development of immune system. Secondary, consequences of disease, drugs, nutritional inadequacies, and other processes that interfere with proper functioning of the mature immune system. Primary immunodeficiency. So it is disorder of specific immunity. So it can be humoral immunodeficiency, B cell defects, or cellular immunodeficiency, T cell defects. Disorders of innate or non-specific immunity, combined immunodeficiency, B and T cell defects. Disorders of complement deficiency, disorders of phagocytes deficiency. So clinical suspicion because of recurrent infection, chronic infection, infection with unusual opportunistic infection agents, poor response to antimicrobial agents, chronic diarrhea, failure to thrive, hepatosplenomegaly, autoantibodies, autoimmune diseases. Primary immunodeficiency, in that disorders of specific immunity, saying that we will see humoral immunodeficiencies, that is B cell defects. So the example is Bruton disease. It is X-linked A gamma globulinemia. So failure of pre-B cells to differentiate into immature B cells in the bone marrow. So due to absence of enzyme called Bruton tyrosine kinase, so which causes transformation of pre-B cells into immature B cell. So total absence of B cells and plasma cells in the circulation. Pre-B cells are found in normal numbers in bone marrow, and T cell mediated response are normal. Cytoplasm of pre-B cell may have incomplete immunoglobulin, X-linked primary in males. Sporadic cases may be seen in females. Secondary infections are seen after 6 months. So because of the maternal antibodies are depleted. So recurrent bacterial infection, then viruses that are cleared by neutralizing antibodies, enteroviruses, parasites like Giardia lamblia. Cellular immunodeficiency, D cell defect. Example, D. George syndrome, thymic hypoplasia. Results from congenital defect in thymic development leading to defect in T cell maturation. Infants are extremely vulnerable to viral, fungal, intracellular, bacterial, and protozoan infections. Pathogenesis, in 90% of cases, there occurs a depletion affecting chromosome 22q11, which leads to developmental malformation affecting the third and fourth pharyngeal pouches in embryonic life. Thymus, parathyroid glands, and portions of face and aortic arch become defective. They may be associated with parathyroid gland hypoplasia, resulting in the neonatal tetany and hypoglycemia, hypocalcemia, abnormalities of heart and great vessels, Fallot's tetralogy, characteristic facial appearance. Treatment, thymic transplantation has been found to be successful in restoration of immune function. In others with partial defect, immunity may improve spontaneously with age. Combined immunodeficiency, B and T cell defect. Example, Wiskott-Eldrick syndrome, X-linked recessive disease characterized by immunodeficiency with thrombocytopenia, eczema. Severity increases with the age. First manifests itself by defective responses to bacterial polysaccharide and lower IgM levels, IgG usually normal. Other T and B cell responses are normal initially, but with increase of age, there are recurrent bacterial infection and gradual loss of humoral and cellular response. Prone to develop non-Hodgkin B cell lymphoma, bloody diarrhea due to thrombocytopenia. Pathogenesis, genetic defect is due to mutation in gene encoding Wiskott-Eldrick syndrome protein present in precursor lymphoid cells of bone marrow. Cytoskeletal glycoprotein CD43 required for actin polymerization. Nazel-Hoff syndrome, autosomal recessive, cellular immunodeficiency resulting from thymus hypoplasia. In some patients, B cells are normal, wherein other B cell deficiency is secondary to T cell defect. Affected individuals suffer from chronic diarrhea, viral fungal infection, and general failure to thrive. Disorders of phagocytes deficiency, Chediak-Higashi syndrome, leukocyte adhesion deficiency, lazy leukocyte syndrome, Job syndrome, or hyper IgE syndrome. Diagnostic evaluation, lymphocytic function, quantitation of specific cell types using flow cytometry, estimation of T cells by SRBC, T cell Rosen test, total lymphocyte counts using differential with complete blood cell count, functionality of B and T cells using mitogen assay, functional status of T cells using skin test, serum antibody measurement, bone marrow irradiation. Phagocytic function quantitation studies using differential and absolute white blood cell counts, cell mobility testing using chemotaxis, metabolic function testing using nitrogen blue tetrazolium NVT dye reduction test, killing ability assay using microcytol activity, complement function quantitation of complement proteins using radioimmunodiffusion, functionality of complement using hemolytic assays, various physicochemical methods to detect immune complexes. Secondary immunodeficiency, variety of factors like malnutrition, protein energy malnutrition, anorexia, malignancies like leukemia, Hodgkin lymphoma, drugs like anti-cancer drugs, cytotoxic drugs, immunosuppressants, steroids, infections like AIDS, tuberculosis, chronic diseases like diabetes mellitus, chronic lung disease, others post-splenectomy, protein losing enteropathy. Diagnosis of secondary immune deficiency diseases depends on the patient's clinical presentation and diagnostic test available for precipitating illness or condition. Treatment depends on taking care of precipitating illness or condition and immunotherapy.
Hope you find this session useful for your understanding and for your exams. Thank you.